Hello everyone, sorry for the small delay because of a technical problem. So thank you for being here today, whether online or on-site, to discuss together the treatment of mitral regurgitation using the Pascal system. So I'm here today with a great fun panel, as you can see. We have virtual people who are joining virtually, Peter Ludike, Susheel, Kodali, and Philipp Raake, and we also have all the panels that you can see. We have some Dawkins, Dabit, Arzamendi, we have Tobias, Geisler, Jorg, Hausleiter, and Philipp, Lurz. We also have as a moderator Wolfgang Rottbauer, and we have Maurizio Taramasso, who's going to be the chat master. So please, we want it to be an interactive session, so feel free to either send your questions to the chat, or if you are here in the room, don't hesitate on standing up, interacting, and we want to discuss with you. So without any further delay, we will start with the first presentation of a case by Philipp Lurz.
Thank you, Nicole. So I'm going to give you a short summary of a patient who will be treated later within this session, most likely, you will see. This is a female patient, 74 years old, obese, who presented to us with clear signs of dyspnea on exertion. Her heart failure symptoms actually worsened recently. She's also known to have permanent AFib, arterial hypertension. She has some coronary atherosclerosis, but no relevant stenosis, impairment in kidney function, stage 3B. These are the most relevant comorbidities. Her current medication is summarized here, and you see that it includes already a couple of diuretics. So that's probably the most important slide. You see the echocardiogram of that patient. Left ventricular function is well preserved. Nothing too exciting in the four-chamber view, but then on the right you see X-plane view, and you can also see on the long axis on the right the pathology. So obviously here something is not quite right, and you can also see that this refers to more the medial aspect of the mitral valve. This is a 3D image, obviously. You can see there's severe mitral regurgitation, and this is due to a medial commissural pathology. And I phrased it quite vague because it could be interpreted in different ways, but it's commissural, and there is a pathology. She underwent coronary angiogram, no relevant stenosis, also right heart catheterization, demonstrating pulmonary hypertension with obviously increased wedge pressures and a predominant V wave indicating significant mitral regurgitation, so a typical finding in postcapillary pulmonary hypertension due to severe MR. That summarizes her other lab results. When you look at the risk scores, you might not think that the scores are that high, but that's probably one of the typical patients where the scores do not necessarily reflect the frailty. She was on assessment, and this was a heart team assessment, clearly considered to be frail, and this is why the decision was to proceed with transcatheter therapy, and in this case using the Pascal device. Thank you.
Thank you, Philip. It's an interesting case. We will be waiting to see how you treated it. But in the meantime, I want to see with the panel. Would you also have went directly to a transcatheter, Jorg?
Well, I was joining the procedure, so of course I would have done the same.
Conflict of interest. Let's switch to somebody else. Wolfgang.
Yeah, I think it's a quite unusual anatomy, and I didn't understand the etiology of the mitral regurg so far. Could you give us some more hints?
Wolfgang, I thought the same. When I went to Leipzig, I thought, oh God, this will never going to be a good case.
Okay.
I could share more details with you, but first we will see more details during the case, and then secondly we had to make a decision with the information I presented to you, so it was also not for us any clearer. Then you could argue whether you should bring the patient back, do another TEE, bring everyone in the same room, or use the image we had. I do agree we had some discussions about what's the exact pathology, but obviously it was degenerative, it was commissural, it was medial, the risk was high for surgery, and this is why we were relatively optimistic, or at least we thought it's a good idea to try to treat it by with a Pascal implantation.
Thank you. So we'll go back to the discussion of this case later, but we have been joined now by Susheel. Hello, Susheel, can you hear us?
Yes, I can hear you well. Can you hear me?
Yeah. Hello and welcome.
Thank you.
So before we discuss, I don't know if you saw the case and what you think of it.
I did. The images were a little hard to see, but it looks like either a commissural leaflet or a very commissural flail. Those can be challenging, obviously. But I think it looks doable, but challenging anatomy. Okay,
so now that in Europe we have been using Pascal for like 3 years, and in the United States you rather have it in clinical studies. So can you tell me what are the most interesting points that you've seen so far with Pascal? The key advantages, let's say.
Sure. Yeah, no, I think there's some important advantages. And, whenever you're choosing a device, you're trying to choose the best device for your patient. There's always pros and cons, and I think we have to consider it. And it's important for us to understand the anatomy. As you said, our experience has been limited in the U.S. It's been due mainly in clinical trials, the class 2D and 2F trials. Oops, sorry, my disclosure went by quickly there. Nothing directly related to Edwards or this device. So the Pascal repair system, it's important in terms of key differences from the MitraClip system is that it's not a keyed system. It's 2 independent catheters that allows you a wide range of motion. There's this rail and stabilizer that allows you much better control than the original system did. And there will be ongoing continued improvements that we can talk about at some point. But there's a lot of maneuverability in terms of gaining height or getting coaxial and things like that. The other key difference, obviously, is the clasp. They're different in that they're a single row horizontally, and they're not aligned on the entire length of the grasper. This probably gives it a little bit more flexibility in some type of anatomies. And also, it's made from nitinol, and so it's in a closed position, and in its resting state, it wants to stay closed. And so, because it's nitinol, there's some flexibility, and that again may help in some regards to valve area, as we'll talk about. There are 2 different devices. There's the Pascal Ace and the original Pascal. The wingspan in terms of where they grab on the leaflets and how much leaflet you need to grab is the same. You can see here the wingspan is 26. What the key differences are on the width of the device, 6 millimeters versus 10 for the Pascal, but also in the width of the spacer, 2 versus 5 millimeters. But functionally, they're the same device. It's just the dimensions are different. And when you're going to a commissure chords or on the tricuspid side, it may play a difference. As we talked earlier, the elements are horizontally aligned, and the idea is that you're going to grab higher up on the leaflet, not at the free edge where it may be less robust tissue, but higher up. And this is sort of theoretical benefit, but in the orientation of the collagen fibers, so potentially have some advantages in terms of regards to retention. This is sort of the concept. This is pre-implant, this is post. You see the device here in the mid, and a similar concept. It's creating a double orifice valve here. The spacer is one of the unique concepts, and in addition to the spacer, and because it's nitinol and has some flexibility, the question is, does this give you some advantage in regards to valve area? I mean, one of the obviously drawbacks of edge to edge is you lose valve area. And this is sort of a FEA analysis, looking at leaflet stresses, but also looking at valve area with and without a spacer. Same implant, Pascal without a spacer versus the Pascal with the spacer. then theoretically there's a little bit less stress on the leaflets, but importantly, there's the valve area in this analysis increases by about 20% during diastole, and that's due to the spacer, but also a little bit of the flexibility of the arms. And then, the ability to elongate, and I'm going to just go to the next slide, but the clip in a closed position, this is the leaflet capture position, similar to what we're used to. But if you get stuck in a case like this, especially in the medial cords, you can elongate. And I think that's important consideration. And this is an example, this is obviously not quite as medial, but say you don't like the position or you're stuck in cords. As you elongate, the retention elements are up top. And as you're withdrawing, the retention elements are not in the direction of tissue. So even if they're engaged in the valve, it should allow you to come out of situations where you're stuck. And this is that concept of getting more valve area because there is some motion with the nitinol elements in diastole. And you can see that in these animations. So those are some of the brief sort of advantages. I think these are theoretical, these are important, and in certain cases will provide some advantages.
Okay, thank you, Susheel. Maybe you can stay with us. We'll discuss later if what we want to summarize. And I'll turn to Jorg, who's going to present to us the main data that we have now with Pascal.
So what do we have? We have initially the American experience from the CLASP study, the CLASP 2-year results, which are summarized here. 124 patients have been enrolled in CLASP, and we have a 2-year follow-up, which has been presented already for 48 patients. You see these kind of patients which have been treated in the initial CLASP experience on the mitral side, around 75 years old. 70% had the functional MR, 30% had degenerative MR. And what is intriguing to see is that you see in the overall cohort a very good MR reduction from grade 3 plus, 4 plus, to 77% at 30 days having an MR1 plus or trace result. And importantly, this results appears to be very, very durable. 78% at 2 years had the same MR1 plus or less result. And if you include the MR2 plus results, then we're talking even about 97% having a good reduction of MR. And this is true for functional or secondary MR, but also for primary or degenerative MR. In the worldwide commercial experience, data from Edwards internal, almost 5,000 patients have been treated on the mitral side with this device. You see here the proportions, how it has been reported, about 50% functional, 30% degenerative, and around 20% with mixed results, mixed etiologies, 99.9%, so very, very safe procedures with no interprocedural deaths or shifts to surgery, almost negligible. And also, when you're looking at the serious adverse event rate, 98.7% freedom of these severe events is very, very promising. Also, the acute results, which have been reported in the procedures, very, very promising. Again, you see this very, very high MR1 plus rate of almost 80%. Interestingly, there is a short learning curve associated with this. So you see the MR1 plus rate is going high very, very quickly. So with the first experiences this is functional MR, here's degenerative MR or mixed etiologies, and the procedure times with a little bit experience comes down significantly. Now, what are one of the major importance? Susheel has already mentioned a few of those. I want to show you some others. We have the opportunity that we can have an independent leaflet grasping, so we can optimize, for example, here the leaflet insertion with an optimization procedure, or we can also use the staged leaflet capture, where we're using the device where we grasp one leaflet first, and the second afterwards. And this will result in an optimized leaflet insertion and an optimized MR reduction. I'm going to show you this, just how it works really in real life. You see how here the anterior leaflet is being clasped. You see the clasp is up, it's coming down. And now we can take all our focus to now try to get to the second leaflet, the posterior leaflet. You see that's pulled up the system. We can see that we have a very deep tissue insertion of the posterior leaflet. Then the leaflet is also clasped. And such technologies where we can really get the best out of it will at the end result in this very high MR1+ rate, because this is really what we need to achieve. We should not be satisfied with an MR rate of 2+ or more. The other important aspect, what Susheel already showed, is the nitinol design from my point of view. The flexibility of the device. Here it's shown on the tricuspid side, but you see on the right side how the device is a little bit opening with each heartbeat. So we are distributing the stress to the leaflets much more better than perhaps with a more rigid device. Does this matter, MR1+ or 2+? We have an ongoing prospective registry in Germany which will elucidate on this, but I can't share the data with you. But we have some retrospective data from the EuroPCR registry with more than 1,000 patients. And you see that those patients who had a residual MR of 1+ had a better 1 year and 2 year survival than patients who had a 2+ or even 3+ MR at the end of the procedure. So MR1 matters, and this should be the goal. We should not be satisfied, as I said before, with an MR of 2+. And these new technologies, as the Pascal device, will help us to get there. So in conclusion, the Pascal repair system is a different system than the other competitor. It has some advantages. The CLASP study has shown a 2-year follow-up, a very robust and durable MR reduction. We have a positive science from remodeling, which I have not shown, and a high survival rate with a reduced annualized heart failure hospitalization rate. This is the CLASP 2 study. In the real-world experience, almost 5,000 patients treated, high MR1+ or low MR rate of 84%. And the more you do, the better you get with your experience, as it is always the case. And this can be done very quickly in very reasonable treatment times. So she already mentioned this. There is a randomized clinical trial comparing the two devices currently, the CLASP 2D and 2F study. These two trials are still ongoing, but I'm pretty sure that we can report very soon some promising data in this regard. Thank you very much.
Jorg, we now heard the technical new features and you showed us the data. Could you try to correlate maybe them to each other more precisely? So let's get started with a spacer. How would we measure outcome of a sufficient spacer in comparison to having no spacer or flexibility? What would be the outcome parameters we would address?
Very important questions. Probably each component is interacting with the others so that we really can be able to dice out which is responsible for what is at the end difficult. Let's say, for example, if you look at SLDA rate, SLDA might be associated with the flexibility of the device, but it can also be associated with the orientation of the clasping, the hooks, more or less. It can be also associated, of course, with the imaging, and imaging between a nitinol and a more or less cobalt chrome device might be also different. So there, I don't think that at the end we can dice out which difference is responsible for what, but those randomized comparisons will help us to understand if the two systems are really comparable, or if one system might be better than the other, or just for some indications better than the other.
Any comment on that, Susheel?
I think in the end, it's going to take time to see these results. And I think in the end, it's about MR reduction. And I agree with Jorg that you got to get to 1+, especially as we treat lower risk patients, younger patients. We got to get to 1+, and that's fundamentally the issue. The rates of SLDA and all these things are really in anatomies that aren't ideal. Whether this device is better than the other in that regard it's going to be hard to sort of suss out, and we're going to have to understand, which anatomies, that have theoretical advantages. But it's going to be hard to show clinically in a trial that one has a lower SLDA than the other. But I think it's a device that you feel comfortable in, and that you think you can get in and out of a difficult case, like the one that was presented deep in a commissure with a lot of cords. Which device do you feel comfortable with is what you should use. But in terms of clinical results, I think we got to get to 1+ with whatever device people want to use. And I think that's fundamentally it. And then the valve area issue is something that we're going to have to sort of look at more closely. And that's going to take a lot of patience. But it's to try and understand that, I think, is an important thing, because I think losing valve area, especially in a lot of these borderline cases, is an important consideration. So, we can look at with data over time as we get large sort of series.
Thank you. This makes sense. I guess we have been joined now by Peter Ludike. Are you here, Peter?
Yes, I'm here. I can hear you.
Oh, hello. So now we're going to discuss with you the predictability of mitral regurgitation reduction after the procedure. But before we go with that, we do that because you've done a study on that. But why is it so important to accurately be able to predict what is going to be the final result before releasing?
Yeah, dear Nicole, dear all, thank you for this question, for this invitation. And first of all, accept my apologies that I'm not with you in Paris, but it was impossible to travel for me. So I'm sorry for that. I tried to answer your question. This is my conflict of interest considering this session. I want to stress this figure out of a state-of-the-art review published 2 years ago that highlights procedural factors that are known from the literature to impact the outcome of our patients, especially all-cause mortality. We just talked about this right now, that procedural complications like SLDA are an important factor, and every interventional procedure bears its risk, complication risk, especially when we compare it to just GDMT. But what is important to discuss about, and this is the session 4, is that residual MR matters and also an increased gradient matters. And I highlighted in this slide also the year of this publication. That's just 2 years ago. And as Jorg Hausleiter already mentioned, is we have a vast increase of available technologies, not only in the field of edge-to-edge repair, but also replacement techniques. And it's interesting to see that there's an ongoing increase of literature and knowledge in the field. And I just want to share these 2 publications from the last issue of JACC Cardiovascular Interventions with you, showing the investigations on what mean pressure gradient seems to be acceptable in which patient cohort. And you see different publications. In the left side, you see that these authors could demonstrate that there seems to be a cutoff in their cohort of 5 millimeter mercury relevant for patients with DMR. There was no statistical signal in the FMR cohort. And when you look on the right, then you can see that these authors couldn't detect any statistic significance throughout the quartiles, even when they compare below 4 and above 6 millimeter mercury. There are a lot of arguments why the discussion is so diverse, and Rebecca Hahn and Jorg Hausleiter wrote a very scholarly editorial on these publications where this table is from summarizing all the evidence we have from clinical trials and single center experiences on the role of the gradient. And I think this is something we need to talk about, and Susheel just mentioned this. It's important to reach out for the lowest mitral regurgitation, the lowest gradient, and we need to consider heart rate, filling status, and all the aspects that can be incorporated in decision making. And the same is true for residual mitral regurgitation. And this is just one of a lot of publications, one of the latest one demonstrating that residual MR greater than 0 or 1 plus matters and is associated with a poor outcome for our patients. So these patients bear the risk of the procedure. and of the hemodynamic effects of residual MR. And before we talk about the predictability study already mentioned, I also want to stress the fact that it's important for us, especially when we interact with our referring physicians and cardiologists, that when we talk about grading, about post-procedural result, that it's important that we talk about the same language, because there are parameters that allow us to quantify in mild, moderate, and severe. It's important to have in mind that even supposedly quantitative parameters like vena contracta width or 3D area are not prospectively validated. But anyway, I think it's important that we take these aspects into consideration and that we use these aspects to quantify this. Well, as you mentioned, we investigated the role of different mitral valve repair technologies on the predictability of the final result. And the motivation for this investigation was the fact that after the launch of the Pascal in Europe, a lot of operators reported after the first implants that they are missing this. In the meantime, we call it the moment of truth. What we were used to from the mitral clip era, that before and after releasing the mitral clip from the steering catheter, we often saw that the residual MR changed, deteriorated, became more, or when there was no MR before, then there came up a new jet. And we had the feeling that these events were less when using the Pascal, and we wanted to somehow quantify this feeling. And so we did a retrospective single-center study at the University Hospital in Essen, and we compared our advanced mitral clip experience with the last 100 mitral clips we've done at our center before we started with Pascal. And since we completely switched our strategy, the cohorts were quite good comparable. They were not propensity score matched. It's important to mention this. But there were no statistically significant differences except for a larger proportion of AFib in the mitral clip group. And what we did was what was quite simple. Two independent sonographers experienced in interventional sonography investigated all the intraprocedural echo loops, and we analyzed the mitral regurgitation signals before and after releasing the mitral clip or Pascal from the steering catheter. And we established a 3-point grading, deteriorated, unchanged, that it needs no explanation, and improved, because we know that there are cases where there is a little residual jet in the color Doppler imaging, and this abolishes completely when we release the device from the steering catheter. So this was more or less some kind of a quality control. This was explicitly not the aim of the study to compare these technologies, because there is a lot of bias in this, but what you can see is that both technology are suitable to reach, in the majority of patients, excellent results in an experienced center. There was a larger proportion of excellent results in the Pascal group, but as I mentioned, this might be biased from strategy and a lot of factors that cannot, I don't want to stress too much. This was the key focus and key primary endpoint of this little investigation, the acute change of MR after releasing an edge-to-edge repair device from the steering catheter. And as you can see, in 1/3 of the cases, these were 32 patients of the 100 investigated patients, we saw a deterioration of the result after releasing the device from the steering catheter. And this was a very rare event in the Pascal group. And when this is important to talk about, when we just focus on those patients where we saw a deterioration, then we can see this is not a disaster. In most of the cases, you see that most of the cases ended up with a still acceptable or excellent result. And these are the patients we need to identify, to talk about, and to learn from. There remain 10 patients in the whole cohort, 10 out of 200 patients, who ended up with increased gradients and a high residual MR, who were not able to, or we were not able to treat them again, to put a second device in or refer them to surgery. So these 10 patients underwent an edge-to-edge repair and have obviously not an acceptable result. And I think this is important in sessions like today that we try, or we should reach out to identify those patients like this old lady I presented these loops earlier, where we have a dramatic MR before, we have an acceptable reduction while the device is at the steering catheter, and when we release the device, then you can see there is a massive deterioration of the residual MR. In this particular case, was a very old patient. The gradient was very high. The anatomy was not suitable for a second device. And so she ended up with this result, what is not acceptable at all. So this is something we need to learn from. And as Susheel already mentioned, I think it's important to identify which pressure gradient is acceptable, especially in multiple device strategy patients, for which patient. Which anatomy is prone for deterioration after release, or is it the technology? I think there is a lot to learn, a very exciting time to be in the field. And so I'm happy to discuss this with you, and sorry again for just being remote. I'm happy anyway to be with you. Thank you.
Thank you for this nice presentation. So obviously, as you said, we still have a lot to learn about the optimal selection and how to predict who's gonna act how. But what's for you the main reason for this difference in between the two techniques? Why we have different results?
I think this is just the meaning. I think that the main difference is the flexibility and the fact that we are not able to put so much force against anatomical structures with the Pascal device. So whenever you try to place the Pascal device in areas of the valve, and I'm very interested how you treated the case in Leipzig, because it's a very medial pathology known for a lot of interaction with chordae. And I think with the mitral clip, you are able to overcome those anatomical forces somehow, and you just realize that you did this when you release it, this very stiff system from the catheter. I think this is, from my experience, the most important factor. I think there are more than this. I think it's, like Jorg said, it's the sum of different, or the interaction of different aspects. It's for sure, I'm pretty sure that the alignment of the retention element plays a role when you compare the techniques, but this might be an explanation.
Okay, thank you. I would like to encourage the audience again, if you have any question or any comment you want to give, don't hesitate either to share your experience or just to ask questions. So now we will try to discuss more about the selection of patients and then to see some cases of patients that were done. So we'll start with Professor Geisler. What are the main anatomical considerations that we should take into account when considering a Pascal device?
So thank you. Thank you. So it's a pleasure for me to moderate this session. It will be a round-table discussion, more a straight-table discussion here for the issue of device selection. And I'm delighted to have experts, experienced implanters with me, who is Sam Dawkins from Oxford and Philipp Raake from Heidelberg, who's connected virtually, and also Dabit Arzamendi from Barcelona, and they will share some cases to discuss the selection criteria for these two devices we heard already about. Maybe I can start a short survey with the faculty, and I would like to ask you, what is the proportion of ACE and the Pascal system at your centers? Maybe we can start in Ulm.
On the mitral side? Or?
On the mitral side, yes.
Yeah, I think we do not use a lot of ACE cases on the mitral side. We still go along with a P10 for most of the cases, and we end up with one-clip procedures and excellent results.
Okay. And in Paris?
In Paris, it's very simple. We have a reimbursement problem. So,
That's good.
So we try to use as much as we can, but I can't share my experience, I would say.
Okay. And in Munich?
It's also very simple. We are 100% ACE.
Okay, so different. And Leipzig?
We are less black and white, so we are 95% ACE.
Okay. So that was actually also our impression within the group of these 4 people, that it's quite heterogeneous from center to center, what we use. These are my conflicts, and we heard lots already about the differences with the devices. And I think it's important that although these devices have differences with regard to size and profile, it's much more about a difference in the design. And so I think we think that we can cover a quite broad variety of pathologies with the ACE and Pascal, with only 2 devices and compared to 4 devices with another system. So it's about the profile, but it's also about the contour of these different devices. And whereas the Pascal implant, the pedals meet the contour of the larger spacer, and that means that the pedals meet at the distal end and gradually recede proximally. Whereas with the Pascal ACE implant, the pedals closely follow the center line, and thus the spacer shape allows pedals to close nearly parallel. And this, of course, enforces the approximation forces. And it's also a difference with regard to the profile. The Pascal ACE has narrow pedals, and this system is also designed to improve navigation through the chordae, and this helps us, of course, as we already heard, in the treatment of commissural lesions. And of course, it's also associated with improved visualization, and that increases confidence during leaflet capture. So we have met internally or virtually several times, and we discussed the advantages or indications for one device or the others. And we came to the conclusion that the Pascal might be better used in functional mitral regurgitation and in cases where the one leaflet is restricted or shorter, whereas the Pascal ACE might be a more favorable option in commissural jets, dense chordae, longer leaflets, and degenerative mitral regurgitation. And there are still some lack or uncertainty of indications where we still need some consensus, and that refers to calcification near the grasping zone, large flail gaps, large prolapses, small mitral valve area, severe tethering, and clefts. And now we will have some cases from the experts here, and we will start with Philipp Raake from Heidelberg, who will present a patient with a large flail gap. Philipp, please go ahead.
Yeah, thank you. Hello from Heidelberg. So I have brought a case to you. This is a 84-year-old female patient, which was referred to our center here with a high-grade mitral regurgitation with a flail leaflet, which was located in the segment P1, P2 of the mitral valve. The patient was symptomatic. She was in HER3. The ejection fraction was 52%. We performed a right heart catheterization prior to this implant procedure, and we could show that the patient has an elevated systolic PA pressure of 65 millimeters of mercury, and also the V wave was elevated at 33 millimeters of mercury. The patient was discussed in the heart team as she was not in a very good physical condition. It was decided that the patient was treated with an interventional procedure. And here you can see the intraprocedural transesophageal images explain you. You can see this large flail as a calcified annulus with calcified cords, which might be the source of this flail leaflet and prolapse here. So it's a degenerative mitral regurgitation, and you can see this eccentric jet coming up here in the direction of the aortic valve, which is typical for this degenerative mitral regurgitation. So for this case, we would choose a Pascal device and a Pascal ACE device, which we always use for flail leaflets or degenerative mitral regurgitation. We are not using exclusively the Pascal ACE device here in Heidelberg. So for functional MR with a broad jet, I like to use the Pascal device. But for degenerative mitral regurgitation, I always use the Pascal ACE device, also because it has these little bit longer clasps and puts a little bit more force on the valve, and you get a little bit more tension, which might be advantageous in flail anatomy. So this was the first grasping attempt, which I performed. Usually the strategy with flail is to directly grasp the flail, which we tried here. It was this first grasping attempt, I was a little bit too lateral, so the result was not perfect. So I went for a second attempt. I went a little bit more medial for this first device and placed the device here successfully. And you can also see that we are in the prolapse here already. And as the result was not perfect with this first device, I choose to put in a second device here directly lateral in the flail position. Turn on the image, and you can see this two devices, Pascal Ace devices here, placed like in a V-shaped position. And this is the pre-implant mitral regurgitation, and this is the post-implant result, which was a very good result for this patient. So mixing devices is not a good idea. So my experience is mixing Pascal and Pascal Ace. It's always a gap between the devices, so I would never recommend that. And for flail anatomy, we always use the Pascal Ace device. Thank you very much for your attention.
So thank you, Philipp, for showing this very excellent case. And in this case, I think nicely showed that with two Pascal Ace devices, we can effectively reduce the mobility in this large flail case. You put the first Pascal Ace in a more lateral position. Normally, we always discuss this with regard to imaging, that we might start at the medial position. What was your strategy here? Could you also have started with the prolapse in the medial position, or was the better visibility of this Pascal Ace device a reason that gave you more freedom to use this strategy? What is your opinion on that?
Yeah, actually, so the strategy for flail is always to directly place your device in the flail, and which I would say works at 80% of the degenerative cases. In this case, we placed it in this lateral position, P1, P2, but we had a large central jet coming up. So that's why we decided to place the first device more medial to treat this more medial regurgitation and to adapt the leaflet, and then we could place this second device lateral, which is the usual strategy to go with the first device medial and the second device lateral, which is a little bit more easier in the mitral valve anatomy.
So thank you for clarification. We have a strict timeline, and I would go over to Sam Dawkins, who will present a case with a short restrictive leaflet. That's just a recent case, I heard.
Yeah, that's right. Thanks very much. So just coming onto my slides. So this is a case, something a little bit different. This is a case from a week ago. So this is a patient who presented to one of our referring hospitals. He presented with breathlessness. He'd had chest pain 3 weeks previously. He was found to have severe 3-vessel coronary artery disease, and he had severe mitral regurgitation with severe left ventricular impairment. As part of his workup, he had a viability assessment, which confirmed a full thickness lateral infarction. And in the process of being transferred over to us for a heart team review, he deteriorated, requiring inotropic support and a balloon pump. So here is his baseline transthoracic echocardiogram confirming severe mitral regurgitation with severe left ventricular impairment. I think the top middle view illustrates the pathology most clearly. You can see that both leaflets are tethered and being drawn into the ventricle, particularly posterior, leading to a posteriorly directed jet of severe mitral regurgitation. As So we had a heart team discussion about him. The consensus of the group was that he was at prohibitive risk for cardiac surgery given his cardiogenic shock, severe left ventricular impairment, and he was also requiring renal replacement therapy at that point. So we can debate the order that you do this, but the consensus from my group was that we would treat the mitral valve first with edge-to-edge repair. So this is the baseline transesophageal echocardiogram confirming the findings of the transthoracic scan. You can see the posterior leaflet is quite short and tethered with a severe jet of mitral regurgitation confirmed with the pulmonary vein flow reversal. There's obviously a bit of a range of views on the panel, but my practice is in this kind of pathology I almost always use P10 and generally try and keep it quite simple and just put a P10 in the middle of A2, P2. The reason for using a P10 in this kind of pathology is the thinking is that the spacer reduces the tension on the leaflets to give a more predictable result and also a lower gradient. So this is the P10 under the valve. You can see we've done a grasp there. I then do a leaflet optimization, so torque the steerable posteriorly, raise the posterior clasp, and then lower the posterior clasp, and then close the device. And you can see both leaflets being very nicely drawn in. And this is the result. Now, you can see that there's a residual jet on both sides of the implant. And my usual practice in this kind of situation would be to open and to move medially and then put another implant on the lateral side. The mitral gradient here was 4. And I would have done that if I hadn't seen the hemodynamic result. So he has gone from having pulmonary vein flow reversal to having essentially normal pulmonary vein flow. And the systemic blood pressure went up by 25 millimeters of mercury. My experience is if you have a result, a really great result, don't mess with it. So I decided not to move this implant. So I released, and what you can see is that the lateral jet has reduced, the medial jet is still there. So I put in a second device, this time an ACE device, so ACE device on the medial side, parallel to the first device, and not quite touching the first device, a little bit separate from it. And so that was a relatively straightforward grasp, as second implants usually are. And this is the final result before release. So we've got a mean gradient of 3. As we often see a second device, the gradient goes down, and that's because you've treated the residual MR. A very nice, stable deployment of both implants. And after release, we have very little residual mitral regurgitation and normal pulmonary vein flow. So we were able to get the balloon pump out at the end of the procedure. He came off his inotropic support over the next couple of days, and I've talked to my team this morning, and he was stepped down from ICU, and he's due to have his PCI later this week. This is his post-procedure transthoracic echocardiogram confirming severe mitral regurgitation has been reduced to mild or less. So a very nice result in a very challenging clinical situation.
That's very nice result and a very challenging case. And your strategy, I think, is more than reasonable to leave the first device there with the effects on the hemodynamics. Would a second Pascal ACE would have been also an option here in this patient? Normally, we tend to use a Pascal ACE as a second device strategy. To get closer to the first one?
Yeah, so the second device there was an ACE.
Oh, that was an ACE.
That is my usual practice. So
Okay.
if I use, so my algorithm, and there's a lot of views on here, my algorithm is if there's too much tissue, so degenerative pathology, I use ACE pretty much routinely. If there's not enough tissue, i.e. this kind of pathology, secondary MR, I use P10. And for any second device, I tend to use an ACE. But there's a range of views on that subject.
And is Pascal P10 your first choice in restrictive leaflets, or what would you have done if the pathology was more commensurate with a restrictive leaflet?
Yeah, the challenge with P10 is that it's bulkier. So if you're steering around cords, it can be a little bit more difficult. But you can always elongate it and sort out the orientation in the atrium and then recross. So I think that's a problem that is surmountable. But usually with commensural pathology, you'd use ACE.
Okay, thank you again for this very nice case. And we move on to Dabit Arzamendi, who will present 2 cases in which he switched from ACE to Pascal or vice versa in a patient with calcified lesion and another patient with a high gradient.
It's a great pleasure being here. So I wanted to present a couple of cases where we had to switch the device from Pascal to ACE and vice versa. And this way, I think we learn a lot about how different these devices can behave. So the first patient was an 84-year-old male that had a prior history of CABG. And he had already a moderate mitral regurgitation at this time, but it didn't got fixed. And the thing is, it got worse over the time, and he started to have shortness of breath, and the medical therapy was optimized, and despite that, he was symptomatic, so he was referred for edge-to-edge repair. And we normally, and we did a screening TOE. We could see that it was a functional MR, pretty central. It looked like a good case. Both leaflets were quite good. Probably the posterior one was a bit shorter, but it didn't look a bad case. And in most of the cases that it has been discussed here, in the functional cases, we favor normally the Pascal device. So they decided to go with the Pascal. And the only thing is, if you can check in here, I don't know if I have a pointer. Is this a point? No. Yeah. So if you check in here, is to explain what happens later. There is this little calcium node just in the posterior leaflet. It appears just at the end of the loop. You see it here. There you are. So there is a small calcium node there. And the thing is that we were able to do a good clasping, but after the closure, the device, it didn't get fully closed. As you can see, the clasp is okay, but one of the paddles doesn't get fully closed, and the MR gets even worse. So the thing is that we did several attempts. We went to the more medial, more lateral, avoiding this calcification. But when you did that, we couldn't fix the MR. So at this point, we decided to switch the device, thinking that grabbing more tissue, we will be able to increase the strength of the device and to get a better result. So at this point, we took out the Pascal device and we switched to the Pascal ACE. And the truth is, just with a single attempt going just to the right spot, we could close fully the device and we had a perfect result. So we learned from this case that, when you need more strength with the device, probably Pascal ACE is the device to choose. But on the other hand, this is the final result, and you can see the MR was really clearly improved. On the other hand, we had a case that we had to switch from Pascal ACE to Pascal. The reason is this was a 61-year-old male that got a heart transplant almost 10 years ago. He had a graft vasculopathy, and he was being studied for a new heart transplant. The thing is that she was symptomatic with shortness of breath, and the echo showed that she had a severe functional mitral regurgitation. So we talked to our heart failure team and convinced them that try to fix this MR. Maybe the patient will feel better, and maybe we could avoid the new heart transplant on her. This is the case. You can see she had a pretty central MR. And the only concern is that she had a good amount of leaflets, so the leaflet good quality. The only thing is in the 3D, you can see these leaflets, they look a bit more rigid. And the truth is that she had a starting gradient of 3 and a valve area of 3.8. So when we started with the case, for the reason that the Pascal ACE, it looks like a shorter, thinner device, we thought that maybe it could be a good choice to get a better result and not increase the gradient. The thing is that, unfortunately, the strength of this device, it's a double, like a double-edged sword. No, you have the good advantage of increasing the strength, but also the disadvantage that you can grab too much tissue in these cases. And the truth is that we did several attempts, and the best result that we got, it was a gradient of 9. That we can discuss if this is good or not, but we thought at this point, that this was prohibitive, and she was a young lady. We thought she deserved a better result. So we switched to Pascal, and what we did is we just tried to do a more ventricular clasping. So since she had a really good amount of tissue, we tried to grab just the tips of the leaflets and use the device as a plug, and not try to grab all the tissue, just to fill the gap where she had the mitral regurgitation. The thing is that we had a really good result, and the final gradient was just of 4. So it was I think it was a pretty clever strategy, and the patient did really well. So this is And these are cases that we try to get some messages from the devices. In the first one is the ACE that gets a lot of strength. In the second one, that the Pascal can behave more like a plug in some cases, and that might be really interesting from this particular case. Thank you.
Yeah, thank you, Dabit. We have a few seconds left. So what is the minimum leaflet insertion you accept for this deep ventricular grasping? What was the leaflet insertion in your last case?
Yeah, so that's what we've been discussing before. And the company suggests that it has to be at least 5. I think the good thing of Pascal is that you can predict the result before you release the device. So if the amount of tissue is not good enough, you will have a residual MR before you release, so you realize that it's not enough. In this case, we went almost down to 3 point something, so it's pretty on the limit. But the thing is that the device was really stable, and we have a good result. I think, and we have already discussed also in this meeting, that this optimization thing is a good weapon to us, because you can optimize, you can reassess, you can do several attempts. This is the other thing, that it's really a soft device, so you can do several grasping attempts without damaging the leaflet. So there are several positive things that can allow us to have a better result. The number, it's difficult to say.
Okay. Thank you again. I think we have seen some excellent cases here, and they show that we can actually cover a broad variety of pathologies with 2 devices, and that also talks on the versatility of these both devices. Thank you very much.
So thank you. We are back now to Philipp, and now it's time to find out how the case went and what was the strategy in this case.
Hello and a very warm welcome to Heart Center Leipzig for Pascal implantation to treat a patient with degenerative mitral regurgitation. I have with me today, and as always, my dear friend and surgical colleague, Thilo Noack. And then we also have the honor and privilege today to be supported by Jorg Hausleiter from Munich, one of the legends in the field. And I dare to say that what we are faced with today is quite challenging. So it's a perfect day to have you on board and to support us with your experience. Without further ado, I'm gonna hand over to another very important person for the procedure, which is Professor Ender. He will guide us through the procedure by performing the TE, and we're gonna jump right into the anatomical and morphological details of that case. Please, Mr. Ender.
Yes, so thank you, and a warm welcome also from my side. You see, there's some flail here. You see that with that ruptured cord? And we can discuss that if it's a P3 flail or whatever. And if we go to the 3D, see that here we have the anterior mitral leaflet, the posterior mitral leaflet, and this is the flail part. So it's hard to differentiate if it's a P3, if it's an A3. In my mind, it's more a commissural additional leaflet.
And what you can also appreciate here are the gaps we are supposed to bridge, obviously. You see the massive MR.
Yeah, effective regurgitation orifice area of 0.9, which is really huge. We have no systolic reversal due to the eccentric origin of the jet. And you see in the commissural leaflet, you see that very nicely, that we don't see here a coaptation point. So we have to adjust the angle in X-plane, and now you see here that flail leaflet with that ruptured cord on the left side.
Yeah, comments. Any comments from the panel?
Still the same, tough case?
But the good thing is that you have tissue. I think they are the cases that you don't have tissues, they are the worst cases. I mean, I think this is a matter of being precise and grasping the tissue that has to be inside. And probably the thing is that all this imaging that has been difficult to define to the echo guy has to be inside the device. So you have to not restructure the mitral, avoid all this tissue. Maybe you need 1 or 2 devices, we don't know, but at least you have somewhere to go.
Yeah, we thought so. I mean, we weren't entirely sure whether it's an additional leaflet or whether it's P3 or A3, but obviously it's a commercial pathology, it is a massive MR, and as you said, there is some tissue which can be bridged, and that was the treatment goal. I continue.
Hello, and a very...
So Philipp, why are you using the A's, or why did you choose the A's over the classic?
Yes, so
Pascal device?
Obviously the difference is the width of it. 10 is compared to 6 millimeter, but the other difference is also that with the ACE device, the spacer is a bit smaller, and I believe that has a certain implication that the two petals, they come closer together. So in other words, I believe that the grasping force is higher with the Pascal ACE, and in a very dynamic environment like this one, I really would like the leaflets to come together as closely and as firm as possible, but at the same time obviously preserving the leaflet and not causing any harm or injury. Okay, so I think for this case and for most, we should make the most of the opportunity to measure simultaneously pressures.
Do you do this on a regular basis, or?
Yes, I really find it helpful. By the way, it's also one of the strongest predictive measures in these procedures of all, the reduction in left atrial pressures. And especially in that case, we have high LA pressures, we have a very significant V wave, and I very much hope and expect, if we do it right, this pressure to come down during the first grasp.
Yeah, I do this as well. I always have a left atrial pressure monitoring, because it tells you right away if you have a good leaflet capture when you close the system and if you have reduced the MR effectively, even faster than any echo assessment.
There we are. So what do we think about the travel, the path of the device? What we see also here nicely is the power of the MR and how the device is pushed away once we are at the center, the epicenter of the regurgitant jet. But that's to be expected. I think it's not bad. I think that's good. Let's open it and check the clasp, because we certainly will use independent leaflet grasping here.
How often are you doing an independent grasping as the first grasp with this device?
Yeah. So we go for simultaneous grasping unless unless it's really needed to do independent. But what we almost always do and use is the so-called single leaflet optimization maneuver, meaning that the first grasp is simultaneously, but then we optimize the one or the other leaflet by do it then independently.
I must say, I changed my way of working a little bit. I'm very, very open for individual grasping, also for the first grasp and swing over. This technique really allows you to have an optimal visualization of the one arm and the one clasp with the leaflet, and then you can swing over to the other one and focus on that one.
Yeah, I totally agree. Okay, we cross the valve. We will double check on fluoro whether we've changed our clocking, maybe a little bit, but that we will see better once we open the device. Let's go to the X-plane view again. We're still in the breath hold. You see, we do have some time, but not endless. Can we see color here, please?
The V wave, I think, is very interesting. It's almost gone. Huh?
That's why I wanted to see color. So I think the pressure tracing there are reliable. Okay, can we have on the view, can we add pressures as well, please?
Wonderful. Yeah, I think this is very impressive. If you see the Pascal is not closed, it's still in its open position, but the V wave is almost completely gone.
Well, let's try that. Okay, let's bring them. Now we can do simultaneously because
they're very nicely on.
Yeah. So we bring down the clasps and we close the device and move in a little bit. Device is closed. All right. Breathing on, and then we discuss everything. Yeah.
I think when the device was closed, one could really nicely see the tensioning on the night. You know how the Pascal was opening slightly, and here one can see this again, how gentle it is. MR is gone. There's at least a little bit of prolapse tissue still
Medially, right?
in the medial part.
Yeah. Can we cursor even more medial, please?
Yes. For this, I have to make the color even smaller.
There's no PISA.
Tiny bit. There we see we have a bit of there.
There's a little bit.
prolapse, but there's no PISA below the leaflets. The hemodynamic effects tell you that you have a perfect result.
Yeah, from a morphology, anatomy point of view, you would think that we add another one to stabilize it. But then you would like to have this one to be even more medial. I totally agree.
Of course, we have the mitral valve orifice is large enough, so we can still place the second one without having a significant gradient.
May I suggest the following? We do another breath hold. We open the device. We will not lose position. And then we can bring up the clasp very gently and then try to be a little bit more medial.
What is your rationale to do this? Just to explain it to the audience.
So it's all perfect now, but I think we also have to respect the anatomy and what we are seeing. So we see still some prolapse left medially, and I think it will be more stable if we go medially and then place another one next to it laterally. You agree?
There's no pathology lateral to it. So
bit of MR though.
Yeah.
Okay, then we open the device.
Okay, go for it.
It's just, at that point, did you thought about the clocking of the device?
Yeah, that's part of the opening of the device, right? Because once it's closed, sometimes it's more difficult to appreciate whether the clocking is perfect or whether the clocking stayed exactly the same. That's why the idea was to open it up, maybe correct the clocking, but also move in a little bit more medially. Because although we did not have a lot of residual MR, we could see that there is still prolapsing or flail tissue, and that was the rationale behind it.
So if we turn a little bit more counterclock, we are respecting more the line of coaptation, and we're more perpendicular to the line of coaptation in this very medial commercial part of the mitral valve.
Okay. Now we can appreciate that the clocking is much more 6 o'clock than we wanted it to be. So yes. And again, it makes the point, some things you can appreciate better once you open the device. Pressures go up now again. That's to be expected, yeah. We will do the clocking in a second, but I'd also like to come more medial. Okay, let's bring up the clasps. Okay, so I'll try to be more medial now. 3D, please. We change the clocking. That will change the medial lateral position as well.
Maybe we can even come a little bit more medial, huh?
Yes, and then more medial if possible, but that's not easy. There is already a bit of tension on it. Okay, explain again, please. Okay, so if we leave the leaflets on, then that's what we can achieve. If we want to be more medial, then we would have to lose the position here. But it's possible, obviously.
Shouldn't we give it a try?
Yeah, well, we have abandoned leaflet tissue on. Let's do anterior first, please. Posterior. Posterior is down. Then we close the device. Okay, so what's important now? To make sure that we don't have MR left medially. This is the clocking is better now?
Yeah, clocking is better, and I think if you can have the color Doppler flow on this 3D, we can nicely appreciate the jets, okay. There's still two tiny jets.
It might be more laterally now because we went more medially, but that's fine because I'd like to place another one there anyway.
I just cut down the plane just to be sure where the color flow is coming from, and it seems that it's really all laterally.
Device looks very stable, and there's no change in the V wave and no change in the Doppler color flow.
Yeah. So You said the device looks very stable. I agree. For the pathology we treated, if you see something like that in functional, then you're slightly worried. But in degenerative, that's to be expected, and it sort of supports our decision to go for second, right? What's the degree of MR now after release? Maybe we should discuss that. I mean, treatment goal, because we all agreed it should be mild or less in these patients. It's moderate is not
acceptable anymore.
It's not acceptable anymore.
I would say it's moderate, because we also I've recorded that. You see still a little bit the systolic wave in the pulmonary vein lower than the diastolic, and it's on the right as well as on the left.
Okay, you can hear that our echocardiographer is quite strict, but that's good, because that gives us better results. He was also not very encouraging to start with, and said that it's not a very good idea to select such a case for life in the box. But we tried anyway. As you could see, we crossed the valve with the device being closed. We normally would not do that for mitral procedures, but because we had to go very commissural, that in that case we actually did it. And you could also see that although we had a sort of acceptable or even good result with the first grasp, we thought that it's important not only to look for color, but also for the anatomy and see whether there is still prolapsing or flail tissue left, and that's why we moved more medially. Any other comments before we continue?
Okay, orientation is fine, but not close enough, not close enough.
The question is if the cords will keep us away from the first device now, so that you have the difficulties to swing close enough over to the first device.
Okay, anterior is a lot of tissue in. Let's bring anterior down, please. And then double check on 3D for the clocking. Okay, anterior is down. We even came above the posterior now, but that's fine. We fix it in a second. Clocking
anterior, you're very close to the first device.
So clocking is fine, right?
Yeah.
Or do you want?
No, I think it's good. Huh?
Yeah, Tilo? All right. Explain. So here you see that posterior, we are above. Go in now gently, because we are in proximity to the first, and we have one already down. Now you see the device rolling. So either we wait until it sorts itself, which it did.
I think now it's not rolling anymore. It's curling because it's so long.
We bring it down. All right. And then I think we are fine to close it. Okay. Okay, so breathing is on. Then we are excited to see color.
There's a little bit regurg. So we check for the gradient.
All right, it certainly did something. We do see some increase in gradient. Yeah, okay, it's only 1 to 2, but at least the appearance of the flow changed a bit.
You see nicely the tissue bridge, all the leaflets are well in the device. And I think it would be very nice if you can now add the color flow to this view, because we saw it before and now it's significantly better. That's all.
I mean, MR assessment is important because we treat MR. But stability, longevity of the result, therefore, I believe it's also important, very important to assess anatomy and the overall appearance of our therapy and intervention. And here, my impression was that we have no distortion. We restored the natural anatomy away from the site of implantation, obviously. So all of these things should be included in your assessment.
So you see that is really traced. So it's 1 millimeter vena contracta and biplane both. So I would say that is really traced to grade 1 maybe.
Okay, let's go to an explain. Cursor on the second device, please. I agree. I think we could have more posterior in. Let's have a breath hold, please. Then we open the device slowly and leave the clasp down still. Maybe we don't do anything, but that's another thing which is worth mentioning and helpful sometimes. If you're in doubt, open the device. I will change the appearance and the interpretation of it. And here you can see that we could be better. Let's bring up the posterior leaflet, please. posteriors up. I go more clockwise. I think we have to come more clockwise. We have to bring up the anterior as well. Otherwise, I can't. Difficult for me to turn. Now it's following, isn't it? Another 3D, please. So I turned to be more 12, 6 o'clock. Okay, good. We bring down posterior again. There you go.
This looks very nice.
Okay, so we have full leaflet in, but no annular tissue. And then we close. Can we pressure tracings on screen, please? Okay, we close.
While we're closing.
Okay, pressures came down again, breathing on. All right, let's do a final assessment. Look at that, and then also at the level of the leaflet, maybe from an LV view, because here sometimes it's overestimated. I mean, please remember we started off with a massive torrential MR with an ERA of 0.9, and now we look at small jets. We have tremendous improvement in pulmonary vein flow. We have a tremendous improvement in left atrial pressures. Mean LA pressure came down by 10 millimeters of mercury. V wave came down 30 millimeters of mercury. Can we have the preview again, please? The initial baseline MR, just to remind ourselves with what we've started off here.
So this is the measurement of 0.9, and here we see that was the vena contracta in biplane. So a huge MR, and that is actually what it is right now.
In conclusion, we had a quite challenging and pretty unusual anatomy, at least something we don't see every day. We had the great advantage of having a surgeon with us explaining of what we are looking at here and what it looks like in situ during surgery.
So without any bias, I think most of us would agree that this is a perfect result with probably an MR 1+ residual MR.
Very nice case and very impressive results. We have some time for comments or questions from the audience. If you have any, don't hesitate. I've noticed that you do all your grasping with a breath hold.
Yes.
Systematically.
Almost always, unless it's really pretty straightforward. But in anything more complex, we like to do breath holds because obviously it gives you more stability, less motion. Normally, during ventilation, the device is moving from medial to lateral, and by have a breathing stop, you get rid of that motion, and the procedure is much easier, and you can be more precise with your steering and with the implantation.
Okay, and we've also seen the optimization. Do you have any tips and tricks for when we want to optimize, when we want to detach and then optimize on another leaflet? What are the checkups you need to do before?
I guess my advice would be that grasp leaflets, but then really take your time and assess everything very, very, very thoroughly. And if you're in doubt, as demonstrated and also discussed, reopen the device because it will help you to understand what you've done and what you potentially could do better. And there's absolutely no risk with that device. If you just open it, you open the pedals, you still have the clasps down, the leaflets will stay in place. There's no risk of losing them, and there's also no harm to the leaflets.
And I think it's an amazing case. And we always discuss that how important is the transeptal puncture. And what about, I think this is a especially particular scenario for that.
Yes. So what we do now more and more often, obviously we aim for transeptal puncture about 4 centimeters, and we try to be posterior. But in more complex anatomies, what we normally add is we double check on a 3D and try to appreciate where we have the tenting and correlate that to the medial commissure. And with that device, you find it much easier and much more straightforward if you really enter the left atrium just above the medial commissure, and also for this case.
Okay, so maybe one last question.
Yeah, there's a question.
Go ahead.
Just wanted to ask you, what is the rate of complications here
The procedure is extremely safe. The complication rate is very low. When you look at the studies, obviously that includes a certain learning curve. There's some SLDAs, but there's no major complication. I don't think that in the studies there are any conversion to surgery reported, not that I'm aware of. And in general, the extremely safe procedure. Well, it's not so much about the complications, but it's really about obviously achieving an MR reduction as good as possible.
Perhaps usually in these high-risk patients, we're looking then beyond in-hospital outcomes, the 30-day outcomes for severe events, mortality or something like that, is somewhere in the range of 1 to 2% in very high-risk patients.
It's worth mentioning that with the patient that I presented, this is a patient in cardiogenic shock on inotropes. It's still a safe and predictable procedure and very, very hemodynamically benign. And actually, if you look at the commercial data that you presented a second ago, the risk of mortality or conversion to surgery in the commercial data set during the procedure is 1 in 1,000, which is a very, very low risk that we can tell our patients.
Indeed, probably the worst complication is not being able to improve the result. So sometimes the message that you have to give is that the worst thing that can happen that you leave the cath lab with the same result that you got in at the beginning. So
one of the really nice things about these procedures is that procedural complexity does not correlate to patient risk. If you have a difficult TAVI, for example, that's usually high risk for the patient, but a difficult mitral or tricuspid procedure is not high risk for the patient, it's just more difficult for the operator.
Any other questions from the audience? So maybe I'll let you give us the key learnings that we got from today.
So what did we learn, or what did I learn? First of all, I think there's a new kid on the block, we would say. It's not just a copy of the mitral clip, the Pascal system. It has very interesting and unique features, and I think we need both devices to advance TARE for the help of our patients. I think this is the first key learning we heard today. Second is we are eager to collect data for you and randomized data. Even randomized data are on the way. Jorg highlighted that will help us to say what's the best device or in what indication do we use what device. And then there was this other discussion about ACE and P10. I learned also there that you can go different ways, but I think there was even a question on the chat that said, explain your strategy and decide before you go into a procedure about your strategy. And if you have a good strategy, you will end up with good results no matter what device you're taking. But we are all sure that we need the improvement of the P10 to the ACE. We need these two different devices for different indications, and I think this was highlighted too. And I think these were the most important things I learned, and this was a very tricky case. Congratulations again. I think this is not standard. We didn't show it because it is standard, but it shows us what's doable with a not very invasive procedure, and really helps the patients and doesn't put it at risk. And I think it would be harmful to the patients if you guys wouldn't have tried to treat it that way and that elegantly, even with the legend around. Yeah. Okay, with this, thanks to the sponsor of the session. Thanks to the discussion panel, and I wish you a nice evening.